Okay, so good morning, everyone. I'll be talking to you about Acanthamoeba keratitis, which is fortunately not that very common, but unfortunately, it is diagnosed only after the patient has been treated for other microbes many a times. Only sometimes when you take a meticulous history and it has been attended very well, then you get to know that yes, probably it can be Acanthamoeba, and for that you need to have the highest degree of suspicion. For that you have to understand that most of these patients, they are contact lens users, particularly who don't maintain the contact lens properly. I would say contact lens abusers rather than contact lens users, because they sleep with contact lens, they swim with contact lens, they don't do care and maintenance. Sometimes for orthokeratology, people have used homemade saline tap water they have used to clean the lens. All sorts of things has happened. Or sometimes it can also happen to a farmer as well. Apart from fungal keratitis, he can have an Acanthamoeba keratitis because of trauma to the surface of the eye, contamination with brackish water, contaminated water, and that can be a reason. Why I said tap water? Because this was one study which was published from UK, wherein they studied the tap water and found out that nearly 80% of the tap water had some amount of these parasites, the Acanthamoeba, and you can understand that in tropical countries it can be even higher. So Acanthamoeba keratitis mostly is unilateral. It is associated with severe pain, particularly in immunocompetent patients, those who are diabetic, those who are having HIV, those who are in any way immunosuppressed, then they can have painless Acanthamoeba keratitis as well. And redness, photophobia, blurring as in any corneal ulcer. So when hardly you get to see patients in their early stage, because many times the patient comes to us after getting some treatment or after showing somewhere. But initial cases, you can get some epithelial irregularity, you can have some dendritiform appearance, and you can also have patchy stromal infiltrates, you can have radial perineural infiltrates, but in large majority of cases, patients come with ring ulcers, with total corneal staining and epithelial defect, with inflammation. A couple of decades back, whenever we used to see inflammation in the eye, we always used to feel that it can be either viral, it can be bacterial, but in Acanthamoeba also, there's a lot of inflammation that can be seen. There can be anterior chamber reaction, there can be scleritis, limbitis, all sorts of things. And ring infiltrate is something which can be seen in Acanthamoeba as well as Pseudomonas keratitis. Now, the difference that you can make out from differentiate between these two is by the history, that in Pseudomonas keratitis, it will be a very rapidly growing and fastly progressing ring infiltrate and lead to rapid ulceration and perforation. But in Acanthamoeba, it is a slowly progressive condition. And as such, ulcer does not have that much of vascularization, but it can be associated with scleritis and limbitis, wherein you can have you can have vascularization. Now you can see this is an example of an Acanthamoeba keratitis post refractive surgery. Started with this ring infiltrate. You can see here the ring-like appearance, and then the total epithelial defect is having. Then the patient had nodules in the sclera, and it went on progressing from one nodule which became atrophic. Then it in adjacent area there were nodule, and gradually there was a 360-degree thinning in this case. As far as diagnosis is concerned, it can be done by meticulous history taking, by the symptoms of the patient, and also by corneal scraping and by confocal microscopy as well. So in confocal microscopy, you can get to see thickened nerves, and you can see the double-walled cyst as well as trophozoites. So you can see the thickened nerves. And then as you move further anterior, you can see double-walled cysts in the stroma. And as you further come anteriorly, you can get to see these refractile trophozoites in the basal epithelium of the cornea, of the ulcer. And when you stain with chalcofluor white, you get to see these apple green fluorescence, and you can, all these double wall cysts can be stained nicely with PAS as well, although the trophozoites are not the ones that can be detected so easily. As far as culture is concerned, it is culture in non-nutrient agar with live or killed gram-negative bacilli. The basic idea is that Acanthamoeba eats up these gram-negative bacilli, and that's what you get depressions or trails in the culture plate. But as you, but even in macrophages, etc., you can have these depressions. But on serial transfer, again, if it's causing these depressions in the next plate as well, then that is suggestive of Acanthamoeba. And PCR again is a very sensitive tool to diagnose. As far as treatment is concerned, aggressive treatment has to be done by use of bigonides and diamidines, chlorhexidine 0.02% or polyhexamethylene bigonide 0.02% can be used, and propamidine 0.1%. Both can be combined, initially can be given hourly, and then gradually you can reduce the frequency. You can use systemic therapy with azoles, and another drug which is now coming up and started becoming popular is miltefosine. It is an anti-leishmania drug, and there was some animal study in which it showed that systemic miltefosine as well as even topical has also been used, have some good effect in Acanthamoeba. There are studies which have shown good results. There are reports of severe intense inflammation as well as limbal and scleral necrosis also happening after addition of miltefosine. So that is why there are few case reports only, but it is not yet considered as an established modality. It can be used as an adjunctive additional therapy if it is not responding, a proven case of Acanthamoeba keratitis not responding to bigonide and propamidine. There are studies, they have also shown that instead of 0.02% of chlorhexidine, they have used 0.06% for some time with good results, and then they reduced to 0.02%. So all these things can be done. As far as steroid is concerned, it is usually not given, but if there is scleritis, if there is uveitis, you can give steroid, but nicely undercover with bigonides so that you can have suppression of inflammation. As far as the scleritis is concerned, systemic steroid is, of course, it is useful. It can be given initially, but mycophenolate has been found to be quite effective. So the usual dosage schedule will be 500 milligram twice a day initially to start with. Then you increase it to 1 gram twice a day, and then you increase it to 1.5 gram twice a day. And then later on you can reduce depending upon the response. Supportive therapy in terms of cycloplegic and anti-glaucoma has to be given as in any other keratitis. What is most important, that many of these patients have severe pain, very severe pain. You have to give NSAIDs to reduce the pain. If it is not responding to NSAIDs, you have to give sometimes these opioids, tramadol, etc. And a couple of patients, I have used these patches also of lignocaine and amitriptyline patches have been used to reduce the pain, because patient is in intense pain and always complaining. So you have to take care of that. CXL and PTK have been used in 1 or 2 case reports, not very effective. As far as keratoplasty is concerned, the risk of recurrence is very high. So if you are planning to do a lamellar keratoplasty, it should be done. You have to judge it that it is not responding in the initial stage, then you may go ahead. But it is always advisable to control the infection first to a great extent, and then only go ahead with any sort of keratoplasty. So thank you very much for your patient listening. Any suggestion, anything you would like to add? Yeah, yes, sir. Sorry? Lignocaine patch. Yeah, it is available. You just have to put it over the skin somewhere, and that there is sustained release, and that reduces the pain. Yeah, like fentanyl. Yeah, yeah.